I think we're going to go ahead and get started. Welcome to everybody. A lot of new faces, which is great. We love to have guests from outside the department attend our Grand Rounds. Today we are honored to have our Director of Brain Injury, Dr. Alexandra Nielsen, give us a talk. Dr. Nielsen is a native of Iowa, where she did her medical school and did a residency at Ohio State. She did a brain injury fellowship at NYU and is an assistant professor in our department and director of brain injury. So we're really honored to have her give us a talk on headaches after brain injury.
Thanks, Dr. Mitra. I'm going to apologize if I have to take a nose blowing break. I'm working on a cold, but I think we'll make it through. So we're going to talk about headaches after brain injury. I first started being interested in this actually as a resident because I kept seeing everyone complaining about headaches and I had no idea what to do for them. And so I was like, gosh, I should probably read more or learn more about that because this is a recurring theme. So that's kind of the first time I started doing this, and ever since I've just kind of been expanding my knowledge in the area. So just a couple simple learning objectives really. Really just defining and classifying the headache. I think sometimes that's almost the hardest part is these people come in and they have headaches and you don't even know where to start. And so I think part of the best place to start is figuring out how to better define or classify what we're talking about. Additionally, my own passion is the impact of post-traumatic headaches, so that's what we're really going to focus on here today. And really, I'm going to contend that the impact is really pretty large, and larger than we even know, and larger than we're even addressing or paying attention to. We're going to talk about some of the available treatments for patients with post-traumatic headache, and I think you'll find that one of my take-homes is that we're really not doing a good enough job in the research realm of things in terms of really understanding how best to treat these patients. So there's going to be a lot of question marks and unknowns at the end of it that I think need to be addressed with some clinical research. And then we will talk a little bit about the evidence and recommendations that are out there so that you kind of know what the status quo is and where we should go from there. So I'm just going to dive right into definition and classification. Residents, how many of you have ever heard of the International Headache Society or the International Classification of Headache Disorders? Not a single one, right? Oh, because I told you? Okay, yeah. So this is the problem with especially in PM&R, we don't a lot of times own headache, you know? And the problem is we see a ton of headache. And as a resident, you don't know where to start. You're like, I have no idea where to start. So I would encourage you to start here. They have a website where you can kind of learn about all the different kinds of headaches and diagnostic criteria for those headaches. And that way you can start to kind of classify headaches in your brain and kind of figure out where they go. Sometimes even just classifying the headache will help kind of lead you down the path of how you should be treating it. So 2004 was the second edition, and then they have a beta edition that's been kind of in testing since 2013. They're not too different. But they do have a great website that you can go to and kind of, look at the different classifications, and I would encourage you guys to do that. So these are the sort of main parts of how you classify headaches. So there's primary headache disorders. This usually ends up being in the realm of neurology for the most part, or some of the pain physicians. Obviously, we'll see these primary headache disorders. And where we come in and where I think that we need to be more active is in these patients that have secondary headaches. And I think sometimes we forget about that, but it's a huge portion of, it's a third of the headaches that they're describing here. So, and then within that, they kind of break it down into subcategories, and we're going to focus on category 5 and 6 today. Category 5 being the headache attributed to trauma to the head or neck, and category 6 being a vascular disorder. We'll just briefly touch on that. And those are some other things. So, should we spend a lot of time on this? I say yes, so I'm going to tell you why I say yes. The numbers for TBI, every time I check the CDC website, they just go up. Like 2 years ago, they were 1.7. Last year, it was like 2.5. Now their website says 2.8 in 2013. And I expect that to continue to skyrocket as awareness is made more prevalent and people just start identifying that they've even had these concussions. And about 80% of that is mild TBI, and you'll see why that's going to matter in this discussion about post-traumatic headaches. So that's a lot of people. That's not a small number of people. So these people are out here, and they're going to end up in your clinic. So when you talk about symptoms after TBI, there are a bunch of symptoms after TBI, but by far, headache is the number one symptom after TBI. It is the most common and the most persistent symptom after TBI. All the other ones, cognitive impairment, dizziness, balance impairment, sure, they have those, but headache is the number one complaint. And it's especially common after mild traumatic brain injury. So if you look at that big number of 2.8 million people, you take 80% of those as being mild traumatic brain injury people, and their number one complaint being headache. My question is, why don't we talk about headache more often? Because that's clearly the number one thing that our patients are going to care about at least. So the cumulative incidence, so you're thinking like, okay, so maybe a few of these people get headache. Well, if you take the cumulative incidence over the first year, 91% after mild traumatic, that's like everyone, okay? So every single person of those 80% of the 2.8 million TBIs is gonna have a headache. That's crazy, right? That's an amazing number of people. And even in the moderate or severe category where it's less common, the 1 year cumulative incidence is still like 71%, which is again, a huge number of people. If you look at prevalence, and this is kind of like in the first acute period, the prevalence is anywhere from, people quote 30 to 90%. Again, it usually hangs out, most of the studies that you see, in like 50%. This is kind of my lit review. I just looked at the different prevalences that were reported, and you end up seeing these right about 50% numbers. This part is even more depressing. When you go look out a year later, see that 53%? That didn't change a whole lot. So we're talking about people who are going to have this symptom for at least a year after their injury. And I think a lot of the new research, when you go and look at the studies, they're showing that these prevalence numbers aren't really changing a lot over this first year. So certainly we tell people, concussions, mild traumatic brain injuries, you should get better in a few weeks. But there are going to be a proportion of people who are going to have prolonged symptoms and going to need prolonged care from these sorts of injuries. So when you looked at this is just one of the studies that you can pick out there, pain and sleep and post-concussion. 40% of patients reported headache in the first 6 weeks. And then I think this is the important part, right? Headache is fine, right? If you can still do your job, go to sleep, do what you want to do. But that's usually not the case in this patient population. These headaches are really quite debilitating for these patients. And so they have adverse impacts on mood, they have adverse impacts on sleep. And if you have a headache and you're not sleeping well and you're irritable, things can kind of spiral downward quite quickly. And so these people reported a 3-month and a 1-year post prevalence that were like a little bit better, right? So a third of patients still reported headache, so that's better than that 50% staying average across the line, but still a significant portion of people at 3, 6, and 12-month follow-up still talking about those post-traumatic headaches. And these authors bring up, and rightfully so, the interplay between the post-traumatic headache and also the cognitive and mood consequences that occur with brain injury, and kind of how do you figure out where that happens. I don't think there's a neat way to uncouple those. I think we just need to be aware that they're there together, but it shouldn't mean that we just forget or ignore the headache altogether. So when we talk about post-traumatic headache, we're talking about risk factors and protective factors. So a lot of the studies early on would say female gender was a risk factor for developing post-traumatic headaches. There have been some more recent articles where I've read where other people have said no, there was no gender prevalence. So maybe just something to keep your eye on. The big one is that second one underneath there. If your patient had a prior history of headaches, you need to know that going in, because your success in treating that and the chance that they're going to have a continued headache disorder or a worse headache disorder is certainly pretty high. So that's a question that I ask all my patients. My residents know on my template. That's part of that history that we take in someone who comes in with a concussion, because it's really important for you to know. And I'll even anecdotally, I will broaden that a little bit. I think you should be asking about any chronic pain disorder. I've had patients with interstitial cystitis, fibromyalgia, some of these other chronic pain, somaticizing disorders, and I think it's important for you to know that going in so that you can manage expectations appropriately about this headache disorder that may develop. Again, mild severity of injury is going to be a higher prevalence of the headaches. So in your patients who you're calling a mild traumatic brain injury or concussion, you should be asking about headache. You shouldn't be waiting for the patient to tell you. You should be asking about that so you can actively manage that. And then psychiatric or emotional symptoms tend to kind of eke in there as a risk factor as well. Protective factors, our older patients tend not to complain about headache as much. So just take that for what it is. So what do we call a secondary headache? How can we call it secondary? So it's very arbitrary. They pick 7 days, okay? So a close temporal relationship to a known trauma or event. So you take your history, they fell down the stairs, they hit their head, they had a headache that started the next day and went to the emergency department. That meets criteria for a secondary headache related to a post-traumatic headache. That meets criteria. That's really all you have to do. And again, that 7 days, everyone kind of notes that that's very arbitrary in nature. So take that for what it is. The other thing that you can have is those patients that are high risk, that have a primary headache disorder, if their headache is worse after a trauma or event, and that's, again, within 7 days, they tell you about that worsening. And so that's the other way you can get it. A worsening headache can then be considered a post-traumatic headache. And usually patients will tell you, like, this is not my normal migraine. I hear that a lot. Like, I had normal migraines, then I had my fall, and this is not my normal migraine, and here are all the reasons why. And so then I will code their primary migraine disorder in addition to a post-traumatic headache disorder, because really then they have both. The other question I get a lot is, what if the person's like in a coma for 6 weeks and then they wake up and they have their headache? So they specify that it can be when they wake up from or are able to start reporting. So that's when their 7-day clock kind of starts. The pathophysiology, this one, again, is, I think, a little bit muddy. I don't think we really know. I think even primary headache disorders, we're still trying to work out some of the pathophysiology there. And then at a secondary level, I think people are still trying to figure that out as well. So I kind of, on the right there, I kind of put some of the different people's theories, I guess, about what's going on. Is this myofascial in nature, right? If the patients have a tension-type headache, are we talking about just myofascial strain that's creating a headache? Are we talking about nerve injury, nerve swelling, nerve damage that's causing a headache? How about direct tissue to the skull, or brain tissue? Should they have like a bleed? Does that cause headache? And then, ligamentous injury, peripheral nerve, or really just the visual and vestibular symptoms, are those causing the headache? There is a paper by Thieler who, this is kind of this box 7 is kind of their take on what is triggering post-traumatic headaches. They kind of use this neuroinflammatory model, which kind of goes based on that, based on the mechanism of TBI itself, right? Why we think concussion is happening. So, excitability in the areas that are, susceptible to pain receptors. And they're saying that this kind of activates this cascade. So whether or not that's true, I think it's still to be determined. I think this is going to be really important. If you're trying to treat something that you don't understand the pathophysiology of it, you're probably not going to be very good at it. So I think the more research we can do in this area is going to be really beneficial for our patients. I always try to talk specifically to the residents about that. Headache is not really a diagnosis. It's really kind of a symptom, right? So if your assessment says headache, that's the same as your assessment saying like back pain. It's like, okay, we can be a little bit more specific than that. We can make a more specific diagnosis to try to help our patient a little bit better and being able to sort of put them into a different treatment column to do a better job for them. And then, like I said, we need to know more about pathophysiology ultimately. So here we are in the post-traumatic headache. So these are all the kind of different ways that you can classify a post-traumatic headache. You can have an acute, a chronic, post-traumatic headache. You can get into like the whiplash section. So again, if you know that your patient had a whiplash type of mechanism, you can get really specific and call it a headache attributed to a whiplash injury. Same thing for like if they actually had intracranial bleeding, you can list that. And then also post-craniotomy headache is a sort of a distinct entity. And I think it's interesting to think about craniotomy as like a traumatic event, right? It is fairly traumatic. I think we also kind of take that for granted, but it's a traumatic event, and so also could be a cause for some of these headaches going forward. So when we look at post-traumatic headache, I just separated acute and chronic out here. And basically, the criteria at the top there are really your criteria for severity of illness, right? Whether you're having a mild or a moderate injury. And then again, that headache that develops within 7 days. For the purpose of this classification system, they use 3 months as acute versus chronic, just for this classification system. And then I think the part that's really interesting on the bottom is that the headaches actually, they don't list any typical characteristics. They don't care what the headache feels like. If it happened within 7 days of a traumatic event, it gets to be a post-traumatic headache. There's no, like, it should feel like this or like that. It doesn't matter. Whatever it feels like, it's a post-traumatic headache. So some people don't really agree with those criteria. And so Thieler put a little bit of, this is their sort of suggestion about how maybe things should be different. And so again, but they still stick with that no typical characteristics known. And so I think that sometimes can cause a little bit of angst for me as a provider, because I'm just like, oh, you have a headache, doesn't matter what it feels like, and it was within 7 days, so we'll call it a post-traumatic headache. Now what? Now what do we do? And the beta testing did add a delayed onset for those patients who some of you have treated, I'm sure, who come in and say, well, my headache didn't start until 9 days later. Well, they have this delayed onset category. And that whiplash, again, we already talked about that. And here's your, they have subcategories. You can get really specific. You guys can go into a big rabbit hole when you're in this, right? You can get very specific. What type of bleeding? Epidural hematoma, subdural hematoma. Just a note on chronic subdural hematomas. Again, like 81%, like this is huge, right? These patients are gonna have headaches. So instead of being shocked when our patients are complaining of headaches, which is sometimes what I think happens, we should really be expecting this and providing anticipatory guidance, and maybe like, you're probably going to have a headache. Sometimes I think just telling people that can relieve some of the anxiety, because the other thing is these people have intracranial injuries. And so if they sense head in their pain or pain in their head, a lot of times they're gonna worry, like, what's wrong? My head hurts again. Am I bleeding again? What's wrong? And so I think sometimes if we do a better job of knowing the numbers and be like, 30 to 90% of people get headaches after their concussion. That's gonna be a normal thing. Perhaps we could relieve some of the anxiety at the beginning. And again, for the subdural hematomas, for people who have them, if we just made the comment to them, you might have a headache with this. That's okay. A headache that feels like this is okay. A headache that feels like this is something you need to go to the emergency room for. I think that would help us a lot. And the headache can be the leading symptom for subdural hematoma as well, so it can be there at the beginning. And then this is just a note, if you have an elderly patient, even with a very small amount of trauma, especially if they're in anticoagulation, you should at least get one image to make sure they don't have a chronic subdural. And then the post-craniotomy headache, again, these are the patients that don't get their craniotomy because of trauma. These are patients that come in, like let's say they have a tumor and they get a craniotomy for tumor removal. They can have these post-traumatic headaches that are from their craniotomy. So I'm going to sound like a broken record, but there's no clinical defining type, all right? So you don't need to worry about what the headache looks like, but what we end up doing is we end up categorizing these post-traumatic headaches based on what primary headache disorder they look most similar to. So do they look like a migraine or a tension type headache? And actually most of the headaches post-traumatic look like migraine. And you'll see why that matters in a minute when we talk about treatment. But there's a significant amount that still do look like tension. The big part on this that I wanted to point out is that again, the same prevalence numbers are there, and then post-traumatic headache within 1 month of TBI a lot of times can resemble that tension, but usually the people with persistent head injury or headaches after brain injury are going to be resembling that migraine. And again, you'll see why that's important here. So I think I've proven, or at least I've tried to show why this is a big problem and we should all care about it, but what are we going to actually do about it? So this was published in the Purple Journal. From a physiatrist perspective, what should we be doing? What should our approach be to these patients that show up with headache after a TBI? So I think number one is important. We're physicians, we're responsible for these patients, and so you need to do your best neurologic exam. You need to know what their neurologic exam is, and if something doesn't fit, if something isn't right, you need to do an intracranial workup if necessary. If they have headaches and fevers, headache and neck stiffness, you need to make sure that you're not just writing off the headache, that you're doing that full, complete exam so you're not missing something. So if you're sure you're not missing something, then we want to characterize the headache typology. So we've already said it's a post-traumatic headache. Now we have to decide, is it migrainous or tension? And then basically the next step there is the time-limited abortive treatment. So the same way you would approach a migraine or a tension-type headache, abortive medications are first. If those don't work or the headache becomes chronic or more than 2 headaches per week, then you should consider for prophylaxis. This is the part that I think a lot of times, 2 headaches a week, that's not that much to us. We're like, oh, you get a couple headaches, no big deal. To the patients, 2 headaches a week is a lot. That could be 2 days they can't go to work. And so I like this guideline because that is really telling us, like, you should be starting preventative medicines for headaches a lot sooner than I think a lot of us are. I think some of us would say, oh, you only have 2 headaches a week, no big deal, just keep taking your Tylenol on 2 days a week. But that's really enough that maybe we need to talk about those preventative headache medications. And I think it can make a huge difference for our patients. This article recommends PT for any headache that appears to have a cervicogenic or myofascial origin or component. So we'll talk about whether or not there's evidence for that down the line. And then I think with any chronic pain condition, that bottom recommendation really is relevant, right? If you're a year out and you're really kind of starting to look like a chronic pain patient, then you really need to talk about cognitive behavioral therapy for that component of it. So we'll come back to this, but I think this is a helpful algorithm for when you kind of feel lost. You can at least say, okay, what pieces of this have I addressed for the patient? And I'll just say these strategies vary widely. In fact, there are a couple papers recently that have published that talk about how like everybody kind of just does their own thing. So it's kind of like the art of medicine. Everybody does what they want to do. But there is a study recently that showed that most people are using a combination of medications and other non-pharmacologic things, whether that be psychology, physical therapy. So probably that would be a best practice to be including both medication management and other forms of treatment. So when we talk about treatment, not a lot of people have done studies in the actual post-traumatic headache population. So what we do is we steal the evidence from other primary headache disorders and use those medications. But there's not very much evidence where we take a group of people with post-traumatic headache and do a randomized double-blind placebo-controlled trial and show that people do better on this or that medication. And so again, we end up relying on treating that primary headache phenotype as opposed to anything else. So to treat the phenotype, we're going to have to know what the phenotype is. And so there are definitions, classic things for migraine and classic things for tension headache that if you're going to do a good job of stratifying these patients, you just need to learn. So the migraine attacks are more severe. They usually last longer. They can be unilateral and have some of these characteristics, a pulsating characteristic or aggravated by physical activity. They usually have at least one of nausea, vomiting, photophobia, or phonophobia. This gets a little hairy, though, in the concussion population because, as everybody here knows, photosensitivity and phonosensitivity are very common in that population anyways. Even patients who don't have headaches have those. So those patients end up endorsing a lot of these symptoms down here, even if maybe they don't have a migraine-type headache. And so when you look at tension-type headache, usually the duration is longer, but also this can also be like that chronic daily headache where it just lasts all the time. And you can see it doesn't really have as many of those nausea, vomiting, photo or phonophobia type characteristics. So there are a couple practice parameters that I think are really helpful. The most recent one is from Neurology in 2012, which talks about migraine treatment. Since 60% of patients with post-traumatic headache fall into that migraine category, it's probably a good idea to familiarize yourself with migraine treatment recommendations. And so this migraine practice parameter for the acute migraine, we talk about over-the-counter NSAIDs, talk about acetaminophen, aspirin, caffeine, or like Excedrin, which has caffeine in it. If you feel like they would benefit from a triptan, you can also use that, again, for an acute abortive agent. What I will caution people with in the triptans is anyone with cardiovascular disease, you should not be using the triptans. So that should be something that sort of rules them out of that medication. The other thing we have to talk about is medication overuse headaches. So this is a headache that occurs on 15 or more days per month due to regular overuse of a symptomatic headache medication. And this says for more than 3 months. So I end up seeing a lot of these patients. A patient has a concussion, they go to their primary care doctor, they're kind of struggling through, and finally at 2 or 3 months they're not better, they still have this headache, which we expect, and they come in and they've been using Tylenol or Advil on a daily basis and they're just miserable. They have a chronic daily headache, they have no idea what to do, and so if I don't address the medication overuse part of it as well as a preventative headache medication, you're not going to make any progress. A lot of the reference texts on headaches will tell you that with medication overuse, you should really think of it when that patient has that chronic daily headache. And oftentimes, if you get them to stop taking the Advil and the Tylenol, you can take them from a continuous headache to more of an episodic headache, which is a huge deal, right? Headache all the time as opposed to just a few days a week. And really, at that point, all you've done is tell them to stop taking a medication. There's a lot of variability about what the textbooks and how they tell you to wean the patient. I've noticed in my patients that they don't do a very good job of weaning themselves. They kind of end up continuing to take it. So I've kind of adopted you should just stop taking this medicine unless your headache is so severe you can't function. And usually that ends up getting them down to they only take it 1 or 2 times a week, and we get out of that pattern of headache. So there are some people that have a very prescriptive wean. I have stopped doing that because I find that my patients don't end up continuing to wean. And so I've just been very direct about it. Like, you shouldn't be taking these medicines every day. You should only take them when you really need them. And then ongoing education and monitoring is important to prevent relapse. It's like in there, kind of snuck in at the bottom, but I spend a lot of my time saying, now remember, you shouldn't take that medicine unless you're really having a severe headache. You can get back into the same problem. There is an Epic. They have a really good, in those smart sets in the wrap-up section for the education, they have a really good one about rebound headache, which is what this used to be called, or medication overuse headaches, that you can print out for your patients and they can kind of read about it later. So I do recommend that as well. So the migraine practice parameter in 2000, this is from the American Academy of Neurology. Group 1 are the good medicines, Group 2 are the okay medicines, and Group 3 are the maybe not so much. And so if you look about in 2000, they were like, yes, amitriptyline is good, propranolol is good, and valproic acid is good. Those were the ones that were pretty good. And then not so much on the other ones on this list. And I will point out the difference between amitriptyline and nortriptyline on this list. I think that's important. And so here's what they gave you for their quality of evidence, their scientific effect, clinical impression of effect, and you can kind of see that this is what happened in 2000. I'm going to move on from this because I think it's more important to talk about 2012. And so if you look on the left, these are the medicines that you should be thinking about when you're talking about migraine prevention. So again, these are those people that are having only 2 headaches a week. Even if they're having 2 headaches a week, you can really start thinking about migraine prevention for these patients. And so things like valproic acid, topiramate, and propranolol are in that level A established efficacy, greater than 2 class 1 trials. So that's some pretty good evidence, more than 2 class 1 trials for a medication like this. Now again, this is for the primary migraine, right? We're not talking about post-traumatic headache, but this is all the evidence we have, so this is what we use. So I use a lot of the valproic acid, and I'll tell you why. I do use some topiramate, but I use less of it, and then propranolol. So the reason I use a lot of valproic acid is I find that a lot of my patients after concussion have some mood instability, and valproic acid is a mood stabilizer. So I find that it's very helpful in that regard, as well as preventing headaches. And we'll talk about side effects later so that we know those. The reason I don't use as much topiramate is, does anyone know the nickname for Topamax? Have your patients told you? Huh? Dopamax, yes. A lot of patients call it Dopamax. They say they feel very dopey on it. Like they kind of just are in this cognitive slowed or fog. And as anyone who treats concussion patients, they already feel like that. So I try not to make that worse. But there have been some recent papers addressing this sort of question, like, is this a good medicine? And one of the papers that I read in preparation for this talk said that the patients didn't really notice much difference. That even though they were already feeling cognitively slow, they didn't notice that much difference. So after reading that, I thought, well, maybe I'll give topiramate a shot as well. And then that second category of probably effective, the amitriptyline, and then the venlafaxine. I like using the venlafaxine as well, again, because it has some mood active properties, and a lot of my patients end up having some mood disorders in addition to their headache. So this is just a review kind of mechanism of action, what we're talking about in terms of activity and dosing recommendations. So these are kind of just there for reference. I will point out a couple side effects that I think are important to remember. Amitriptyline, I always counsel patients on dry mouth, constipation, and then especially females, I counsel on weight gain. If you don't tell them that they might gain weight, they will get very mad at you when they come back 4 weeks later and they've gained weight. They don't like you and they won't trust you anymore. So I tell them about that. Same thing for valproic acid. I talk about weight gain and I even talk about hair loss as well, because the one person you forget to tell about hair loss will lose their hair. Same problem. So I talk to those patients about those things ahead of time. And then in patients with valproic acid, I always monitor CBC and LFTs and Depakote levels. I do that regularly. Propranolol, obviously you have to pick the person that has a good blood pressure and heart rate that can support that medication. And then topiramate, the one that you kind of need to make sure is the history of kidney stones. That's a real thing. People really do get kidney stones on topiramate, and you want to be careful. So what I usually do, and I think the residents, when you guys are in clinic, you've seen me do this, I get a blank sheet of paper and I kind of pick the 2 or 3 medicines that I think are right for my patient, and I write them out, and I write what they do, and I write their side effects, and I let the patient choose a lot of times, because I find that each person kind of has a different preference. I have some patients who hate taking medicines twice a day, or who hate, they had a brother that had something who took that medicine and they don't like it. So I think most of these, as the evidence have shown, are kind of in the same class and probably similar effect. So a lot of times I try to put that patient choice piece in there so that the patients are kind of owning this treatment, especially since I know that the evidence shows that they're going to be dealing with this for a long time for the most part. So I like them to kind of be invested in it early on. So these are the ones that are FDA approved. And so there is a little bit of emerging evidence about patients who actually do have post-traumatic headache, where we did this study. So this is a patient with 100 patients with mild traumatic brain injury and chronic headache and daily headache. They treated them with valproic acid for at least 1 month, and this was a retrospective trial. And then 60% of the patients had mild to moderate improvement in their headaches after at least 1 month. There were some patients, though, that still showed no response, and then there the group that discontinued because of side effects. But so this is like a little bit of glimmer of hope that's maybe that we're on the right track, that using the primary headache disorder and treating the primary migraine might be the right way to go. But we need many more studies like this to really know that we're doing the right thing. And again, this change in headache pattern from daily to episodic, I can't emphasize enough how big of a deal that is for the patient. A daily headache compared to a headache twice a week is like a different life. You can maybe go to work, you can maybe go shopping some days. And so I think from a physiatrist perspective, from a functional perspective, that change is significant. So it's easy to get disheartened as a practitioner because pretty much all of my patients come back and tell me they still have their headache. But then I have to focus on, well, how many less headaches do you have? How many less headaches day per month do you have? And that's where it gets important to make sure that your patients are filling out headache logs. Because if they don't fill out headache logs, it's going to be very difficult to remember how many headaches you had last week. So I, as a practitioner, hand out those headache logs to the patients, and I really encourage them to bring them back in so that we can really highlight, like, okay, we started this medication, you used to have headaches 5 days a week, now you only have headaches 2 days a week. That's a big deal. And sometimes if you don't highlight that for the patient, they're not going to see that for themselves. So this is interesting. Back the first time I did this presentation, there was this study about amitriptyline to prevent headache after traumatic brain injury. And it said that it was going to be completed in July of 2015. I have looked everywhere for this study. I scoured the internet. And if anyone can find this study, I'm very interested to know what happened, because I can't find the results. And I am super intrigued if we started amitriptyline before patients had headache, because we know so many of them are going to get headaches. Would we prevent this terrible, terrible thing that happens to these patients? So if anyone can find this, please let me know, because I looked really hard and I can't find it. I'm thinking about just calling these people eventually and seeing what happened with their study, because I'm very interested. So then the question, what about neurotoxin? It's a good question. Neurotoxin is only approved for chronic migraine. So neurotoxin is not approved for tension type headaches. It's only approved for migraine type headaches, and it's only approved if it's chronic. A billing note, if you just diagnose your patients with post-traumatic headache, that is not a qualifying billing diagnosis for neurotoxin. So you might have to also describe the fact that they meet migraine criteria by their symptoms and that they meet chronic migraine criteria. So just a billing note if you're going to do neurotoxin. And so headache on greater than 15 days per month. This is also why it's helpful to have a headache diary, because they can come in and you can be like, I saw they had 17 headache days last month. They meet that criteria. And then again, duration of greater than 3 months. Usually not a problem for the physiatrist, because usually by the time we get them, they've been struggling with this for a while. And so The PREEMPT trial is a trial of onabotulinum toxin A, where they gave 155 units or placebo at 31 fixed site, fixed dose injections in 7 specific head and neck muscle areas. There was this extra 40 units. Those of you who do neurotoxin know that these come in 100-unit vials, so the only way to administer 155 units is to order 200 units. So there's this extra 45 units hanging out there. And so they were allowed to give these 40 units to sort of follow the pain, right? So if you had more pain in your right temporal area, you were able to increase the dose in that area, or if you had a lot of shoulder discomfort or trap muscle pain, you could follow the pain. And that got them to 195 units. I am not sure why they disposed of the last 5 units. I don't know. These are the 31 prescribed sites. So you can see that you end up doing kind of a frontal section, a bilateral temporal section, an occipital section, kind of a cervical, upper cervical area, and then you get into the traps as well. And so this is a lot of needle sticks, but these are the areas that you stick to. And when I do this injection, I do pretty much follow these sites pretty prescriptively. I follow them. I even have this diagram with me kind of on my chart to kind of keep track of where I'm going. So I do use this. And this is why people have started using this, because if you look at the placebo line versus the onabotulinum toxin line, you can see an improvement there. And so really you see the mean change from baseline in frequency of headache days. And so again, this refocus on headache days, right? Can we reduce headache days? The perception that we're going to get rid of your headache is probably the wrong place to start. So if you start talking to your patient about the fact that we're going to reduce the number of headache days that you have, and that's going to make your life better, I think that'll help your treatment paradigm. So again, just some more of their data from their study that showed that the percent of patients with a 50% decrease from baseline in frequency of headache days and headache episodes. So again, talking to the patient, stressing that concept of headache days. And then here are, again, adverse events before I inject anyone with neurotoxin ever in their face. Ever. And you guys make sure you do this, okay? You should always tell them that there's the chance that they might get ptosis of their eyelid, okay? If you do not tell them that and then you create ptosis of their eyelid, they will be very upset, okay? Same thing if you create some brow asymmetry based on where you put the injection. I mean, you're injecting someone's forehead. So you need to make sure you talk about that, how you're going to try your best to make sure you're as symmetric as possible, but it's something you should definitely talk about before you do the injection so they expect that as a possible side effect. I've only had it like one time, knock on wood, wherever it is. But again, you gotta be careful about that. And then you can see those other ones. This is, I thought, really interesting. All these people that see craniotomies, that you guys know that everyone complains of forever, that just right around my incision, I get this pain and I don't know what to do about it. And so this is a case series. This is not a randomized trial, but it's a case series where these patients were having some really, burning, tingling, some neuropathic peri-incisional pain, and they injected Botox in the peri-incisional region and did get some really positive effects. So this one kind of intrigued me a little bit about how that might be an intervention that we aren't using. 80% pain reduction, that's pretty good. So I thought that was an interesting concept. So something to kind of keep our eye on whether or not that'd be useful in the future. This is just a reminder, migraine versus tension, just to make sure we've covered that so that you can categorize your patient and make sure that you're calling them chronic migraine if they are chronic migraine so that they can be approved for some of these interventions that are only available for chronic migraine. So tension type, education and reassurance is number one because a lot of times that's what you're going to rely on. There's some psychological treatments like CBT and biofeedback. Amitriptyline is like pretty much the only drug that is proven to be effective for prevention of tension type headaches. So I'll tell you that for my patients who I'm really on the fence about their post-traumatic headache, if it looks like migraine or tension, if I really can't tell, which a lot of times it gets muddy, a lot of times I'll start with amitriptyline because it does have proven efficacy in both groups of phenotypic headaches. So a lot of times I'll start with that. And then there is a little bit of evidence for some of the mirtazapine or venlafaxine, especially if somebody had mood disturbance. That'd be a reasonable thing to try. Unfortunately, it makes sense that botulinum toxin would be helpful, but they've done studies and it's just not. So it's only helpful for those migraine patients, so it doesn't help those tension type headache patients. So the behavioral interventions, the kind of bummer part at the bottom is they've done some class 3 studies and maybe their headaches get better. My opinion in this regard is always, I don't know that anyone who's ever been hurt by relaxation training, cognitive behavioral therapy, supportive counseling, education, or biofeedback. I think that that's a wonderful thing, and if anybody gets any benefit from that, then we're all just in a better place. So I freely tell my patients that these are things that they might want to look into, that they might consider, that might provide some small benefit for their headache. What about the neck? This is like an entirely different lecture that Dr. Smith should give, because what I do is I send all my patients to Dr. Smith to help with their neck. The point of that being, don't forget about their neck, okay? Most of the people that have headache also have neck pain. If you're not the neck pain person, don't forget about the neck. Find somebody who will do a good job of evaluating and managing their neck. This is a guy out of UPMC who wrote this sort of Grand Rounds article that really talked about, again, let's not forget about the neck. Perhaps this head pain, especially this posterior head pain, is referred from the neck. And so do a good physiatrist history and physical. Make sure that you're not forgetting about the neck. Then there's this whole other section. Maybe they actually do have a truly cervicogenic headache. Again, make sure you're evaluating for that. There's a whole different category that you can use that talks about cervicogenic headaches. We're not going to talk about that. So then again, physical therapy, what is the role for cervical physical therapy in these patients with especially with these whiplash associated symptoms? So again, I think it's the same kind of concept that we talked about with behavioral therapy. The data really isn't there yet. There's not like a slam dunk study that says for sure that this helps the patients. Anecdotally, I'll tell you, my patients have been helped by their physical therapy. And again, I don't know anyone that's ever been hurt by having a regularly scheduled exercise program with improved range of motion of their neck. Again, I think it's something that can only help people. And when we go back to when we surveyed people are using a combination of pharmacologic and non-pharmacologic. That's what really the standard is across the country, and so we need to incorporate some of these non-pharmacologic things. But unfortunately, there's not a lot of great evidence yet. But I think that people could make some huge improvements there in the research side of things. And so then this also gets sticky, right? Because usually our patients don't just have headache. They have this whole other milieu of stuff, this whole other concussion setup. And so you can see that these headache symptoms they don't come alone, right? They come with all of this other stuff that we end up having to manage as well. And I really like this. This is from Dr. Camioli Reddy at UPMC. I think that this is, especially the residents, if you're going to go into a patient with a concussion and you kind of want to have a plan in your mind, where am I going to go, what am I going to talk to the patients about, this is what you should be talking to the patients about. You should be talking about sleep, mood, cognition, and then these somatic type symptoms, which is their dizziness, their headaches. And you should be addressing all of those things so that you're addressing the whole person, not just one little piece of that concussion pie, okay? And I don't know, we're almost out of time, right, Sharila? Okay, so we will just leave post-stroke headaches alone for today, but they happen and we also need to manage them. So we will go to that have the population-based study. So the incidence, though, is a little bit less. So maybe in stroke patients you won't see it quite as often. So I want to go back to the algorithm. So the patient walks into your office, they have a headache after their TBI or their stroke. Do your good history and physical. Make sure you're ruling out anything that you need to do again. Repeat imaging, all of that. And then categorize your headache. Use abortive treatments. And then if they're having frequent headaches more than 2 times a week, start using a prophylactic medicine. I think that's important. I think a lot of times it gets underused and we kind of underrate the effect that 2 terrible headaches could have on somebody. And then again, considering your other options, number 6 or 7, making sure that you're involving non-pharmacologic and pharmacologic means to help your patient out. And so these are my conclusions right now. Be more specific in your diagnosis. I think that will only help us going forward to be more specific, and you can use these criteria. They're out there, we should use them. And then this second one, I can't really stress it enough. We need more evidence about what is actually happening with these these headaches because they're different, right? Patients will tell you, I had a migraine disorder, I had a traumatic injury, and I have this different headache, right? It's different. Something else is going on. So I think it's important for us to try to better understand that. And then I do really think that we need more randomized control trials about specifically post-traumatic headache patients. We need to start recruiting for and enrolling in double-blind, placebo-controlled trials so that we can have better information for our patients about what might actually help them after their post-traumatic headache. And then again, as always, be a good multidisciplinary physiatrist. If they have neck pain and you can't treat their neck pain, find someone who can treat their neck pain. Make sure you're addressing their psychological needs, their sleep needs. Make sure you don't neglect that other stuff, because as any resident who's ever been on call or recently been on call, if you're not sleeping and you don't feel well, your headache's not going to get better either. I had a mentor that said, when you see a patient with TBI, treat their sleep and their headache, and then worry about everything else. Because if you have a headache and you're not sleeping, you're going to be awful at thinking, you're going to be awful at home, you're going to be irritable with everybody. So treat your headache, treat your sleep, and after you do that, then you can worry about everything else. And so again, I think we need to prioritize those things when we see these patients. These are my references. I have many more too if you guys want them. It's always fun to kind of PubMed post-traumatic headache and see what new pops up. So that's all I have. I want to make sure I save time for questions if anybody has them.
So that was a really great lecture. I think when I was in training, one of the scary things about headache and brain injury patients was the fact that many of them had shunts, many of them had pretty substantial traumas. So could you maybe give us some pearls about, when should you be concerned in a TBI patient about headache, that it's something more than a headache? Could it be worsening hydrocephalus or shunt failure or something like that?
Yeah, so I always tell people you should know your patient's neuro exam really well, and if there's any change in that patient's neuro exam, you should be more concerned and you should get brain imaging or further workup of shunt function. The other thing I do, especially in an inpatient or outpatient setting, sometimes I'll chat with a therapist and say, like, how are they doing? Like, are they still able to do therapy at the level they were before? And if anybody mentions that concept of like functional decline, like they're just not doing as well as they used to be doing, that's definitely a red flag where you need to check a head CT, rule out hydrocephalus. And then any huge change in headache characteristic. So most of these patients get into a very sort of regimented groove of headache, right? This is what my headache feels like. But if they're like, I've never had this before, this is brand new, this feels awful, I usually take that a little bit more seriously. And any other systemic symptoms, so my people who are coming in with fevers, that kind of stuff, that will prompt me to do more workup. But if they're coming in with just their usual headache and none of those symptoms are there and they're functioning the same and their neuro exam is the same, then I kind of continue down the treatment path.
Have you tried the peri-incisional craniotomy?
I haven't, but I really want to.
Yeah, I actually have a patient. I think it'd be good for us.
Yeah?
Will insurance cover it?
I'm not sure. Do they also have headaches?
Yeah, they do. I think
what we could do is use the headache and then use those 40 extra units to follow the pain around their peri-incisional site.
Yeah.
So if they do meet chronic migraine criteria, we could certainly get it approved and then follow the pain around their incision.
That study, though, it said 4-to-1 dilution. Did they say why they did 4-to-1 dilution? Because that's like leg muscle dilution.
I know, but where I trained, it's interesting that you say that. Like where I trained in Ohio, we always did 1-to-1. Where I trained in New York, everybody did 4 to 5-to-1 for every muscle, forearm muscles and everything. Aim and face. So I don't know. I don't know. And I'm sure it was maybe just so that it would spread, maybe kind of diffusely across the scalp is what I'm thinking. To their eye, hopefully not their eye. Hopefully they did their good education about you could get ptosis from this. But no, I don't know. But yeah, I've had different people across the country where I've injected that do different dilutions. So, yeah.
Good. Maybe I missed it. You said difference between amitriptyline and nortriptyline.
Oh,
you were going to talk about it.
Oh, sorry. I'm one of those people. I just think that it's interesting that the data is more strong for amitriptyline as a preventative headache medication than nortriptyline. I don't know why it's more strong. This is going to take forever. I don't know why it's more strong, but in that, now where did it show up in the? Did it show up in this list? didn't show
A little
that.
bit earlier.
It was the earlier list, right?
Yeah. There you go.
So I just thought it was interesting that it showed up in this list where the efficacy was limited for it. Because I see a lot of people using them interchangeably, and most of the actual evidence is about amitriptyline. And my question is, nortriptyline is purported to have a less side effect, but my question is whether or not those side effects are actually helping that patient with headache.
Because with my post-concussive patients, I've had better outcomes with amitriptyline. I usually will go to nortriptyline if they have a big escalation in their liver enzymes, because it's a little bit less with nortriptyline.
Yeah, but I kind
I've
of
had better results with amitriptyline.
Me too. Anecdotally, I've had it, and I think it's because it's a little bit, for lack of a better word, dirtier of a medicine. I think that's my own anecdotal opinion on why it works better. But I thought it was interesting that they did really show up in two separate groups during these practice parameters in terms of amitriptyline really does have the data behind it to show the efficacy.
Can you talk a little bit about how intensity plays a role, especially when you're talking about, reducing their headaches from chronic, like every day, to just 2 days?
Yes. So intensity, I have a hard time with intensity because I have patients who are always like a 75 on the 10-point pain scale. And then I also have patients who look miserable and they're like, I'm a 4. I'm definitely a 4. And they can't concentrate. They're crying. So I personally have gone away from intensity and focused more on headache days because I find that to be much more manageable in terms of patient report and my ability to kind of understand with the patient, what are we talking about? How many days did you have a headache? Because a lot of times I find that in the intensity discussion, I have a lot more extra stuff that gets in there and I get a much more cloudy picture and I have a hard time deciding if I'm making improvement or not. So that's my own personal opinion where I've kind of gone away from severity and stuck a lot towards headache days. Does that answer your question?
It does, thank you. I suspect actually, as you were talking, that the intensity likely goes down along with the number of days that they're actually having headaches. I was just curious whether they happen to mention that or where that plays a role. But I understand what you're saying.
I didn't see as much. I think it's also harder to do research on the intensity, so I think the researchers also stick with headache days because it's a more definable outcome.
As you get improvement in your headache, patients and out of the trauma time, do you have anything structured that when you try to wean people off of the medication or what that looks like?
So I don't wean them off until they don't have headaches. Or they don't want to have the medicine anymore. So if they tell me listen, I'm just really sick of having to take, I was just going to go back to this one. If they're I just don't want to have to take this medicine anymore, I'm over it, then I tell them, well, that's fine, we can wean off of the medicine, but you have to keep a headache diary so that I know if you're getting worse or not. I just had a gentleman who had chronic post-traumatic headaches, and he also, though, I thought had sleep apnea. And so I had him on Depakote, and then I finally was I think you have sleep apnea. And I sent him in, and he got a CPAP, and his headaches are gone. So again, be a good doctor, make sure you do the rest of it. But so then we just had this discussion yesterday. I said, okay, wean off of your Depakote, but call me if your headaches come back, and we'll go back to the dose that you need. So the only way I've found to know if they still need it anymore is to do a trial off if they don't want the medicine. But if they're still having headaches and no side effects, I leave them on. Because there are chronic migraine patients who are on their medicine, for years. And so I don't rush that at all unless the patient wants to rush it. Did you have a question, Katie?
Yeah. Do you have much experience with using Fiorset, and what are your thoughts on that medication?
So I stay so far away from any narcotic pain medicine or any of those addicting type of abortive agents. I talk all day long about how the Tylenol and the Advil and the hydrocodone and all of that is not going to help your headache long term. You and I need to settle into the fact that you have probably a fairly long-term headache disorder that we're going to get through. We're going to make you feel better. We're going to reduce your headache days. And we're going to do it with these medicines that are more for longer term. But I have that luxury because I don't see people a few days after their trauma when they're painful everywhere else, because I see people 2, 3, 4 weeks out when that acute pain should be gone, and it's more appropriate for me to say, we don't need those acute pain medications anymore. We need to talk about what we can do to prevent these. So I think the trauma bend on that is a little bit different because you guys are in that acute period where they do need those acute pain medicines. And so I don't have as much experience in that acute period as much as I do in that more delayed period. So that's kind of an answer, non-answer for you. right. Thank you guys.